So I'll warn you before we go there. This one's going to be a little bit geeky, Geeky, geeky. We're going to get deep into an article. But for those of you, a lot of you have interests in it, and I think it'll help you connect some dots, help you stand with one foot in the new YouTube prevention keto world, low carb, insulin resistant world, and another foot in terms of understanding the old standards of medicine, how they are progressing, how they're beginning to understand some things like triglyceride-rich lipoproteins, TGLP, or what others of us might call remnant cholesterol. So, this is an article in JACC, Journal of the American College of Cardiology. Triglycerides, remnant cholesterol, and atherosclerotic cardiovascular disease. Interesting the way they kicked it off. They said, you know what? We know that LDL is a big risk factor. However, as we continue to get LDL out of the way, there's still a lot of risk there. No comment. Then they go on to say TGRLs, triglyceride-rich lipoproteins, or remnant cholesterol, may be an important contributor to residual risk. There are a couple of different kinds. One is chylomicrons. Chylomicrons are the lipoproteins that come from a triglyceride-rich diet, so they're coming from the intestines after a meal with a lot of lipids in it, or a lot of triglycerides in it. VLDL. Well, VLDL are very low density lipoproteins. They're made by the liver. Then you have IDL, which is intermediate density lipoproteins, LDLs and HDLs. LDLs and HDLs we know about. Again, these big ones with a lot of triglyceride in them are known as remnant cholesterol. If the term remnant cholesterol rings the bell for you in terms of the YouTube world, yep, you see it with Dave Feldman's doing a lot of stuff. He's all over low carb down under. And again, here's why there's that connection there. It's pretty clear that one of the major ways of decreasing triglycerides, whether they're in VLDL, remnant cholesterol, or just triglycerides in your the standard triglyceride in the cholesterol panel, one of the best ways to do that is cut the carbs out of your diet. So let's go back to the article. In terms of epidemiology, they're saying the pendulum has swung to focus more on triglycerides, triglyceride-rich lipoproteins, and remnant cholesterol. Now, when they're talking about this pendulum having swung, they're talking about, okay, LDL, and then maybe focus on niacin. Then they talk a little bit about niacin and some challenges with AIM high and HPS2 Thrive. I've covered that in depth in other videos on niacin. I still use niacin, by the way, and I still recommend it. And they get into some detail a little bit later about why that might actually be a good idea. Now, then they go on and they say, well, it's not really that simple. When you look at ERIC, the atherosclerotic risk in communities cohort, remnant cholesterol was shown to correlate with cardiovascular disease. However, after you started adjusting it for other things like HDL, in other words, a low HDL is going to increase your risk, then it tended to wash out that risk. Well, I mean, think about it. If your HDL is decreasing, we know HDL decreases as triglycerides go up, so you're taking a lot of the same components out of the equation for the research. Anyhow, they went on to talk about Jackson Hart and Framingham offspring cohort studies, other ones which started to, again, help remnant cholesterol emerge as maybe an issue after all. So again, from what they're seeing, the lens that they are looking through, there may be an issue there. Now, if you look at the genetic studies, I'm going to remind you of something that's a little bit mind-bending. Don't get too wrapped around your axle on it. It's called Mendelian randomization. It's basically looking at genetic studies. And here's the thing. Once we realize that with Mendelian randomization, in other words, basic genetics, we're going to have randomized distribution of genes, you can begin to actually tease out potential causality when there's a relationship between a potential cause and a disease. So in this case, the short story is this. In this case, when you start looking at triglycerides and remnant cholesterol and using Mendelian randomization methods, it begins to start looking again like high triglycerides might cause heart attack and stroke. Well, again, it's impressive that we're finding that out, isn't it? So then they go into the pharmacology. Lifestyle modifications are the foundation for management. Isn't that nice that they said that? And it is true. We tend to think that the standard physicians neglect things like lifestyle. The reality is, it depends on how you look at it. Now, you could say that they're neglecting it in this article. They're really not. They start off with the statement of, look, lifestyle's the standard of the foundation for management. In fact, lifestyle will manage 60% of hypertriglyceridemia, or increased remnant cholesterol, or an elevated triglyceride over HDL, or whatever else you are tending to call this. Because this is written by doctors for doctors, however, they start to get deeper into more details of what only doctors are going to be doing, and that is prescription medications. So, yes, I mean, I know I've been guilty of this too, beating up on other docs for not focusing enough on lifestyle. It just happens. Let's move on. So with regards to pharmacology management, drugs can lower this another significant 20%, another 22 to 45%. Now, currently, in terms of prescription drugs, there are three kinds of classes, and one of them is actually both prescription and non-prescription: the fibrates, the niacins, and the omega-3 fatty acids. Let me go back and correct that. I said one of them is both prescription and non-prescription. Actually, two of those classes, the niacin class and the omega-3 class, because there are both prescription and non-prescription levels of niacin, niaspan, versus Enduracin or Rugby. And please avoid the others. And I have no financial relationship or anything else with those two that I mentioned. And omega-3 fatty acids. With omega-3 fatty acids, you can go from all kinds of supplements to the newest, latest, and greatest icosapent ethyl. So, triglycerides and fibrates. Fibrates are fibric acid derivatives. Exert their lipid-modifying effect by, there's a big, long bunch of words here, peroxisome proliferator activated receptor. Those of you who remember it, you may remember it as PPAR, PPAR alpha, PPAR gamma. It's a nuclear receptor. It increases expression of several related genes involved in metabolizing lipoproteins. Helsinki Heart Study, the Veterans Heart Study, others, saw a decrease in cardiovascular disease, but no decrease in mortality. Again, remember, that's probably still means that it works. Decreasing in mortality means there's got to be, as important as heart attack and stroke risk is, it's still only a third of deaths. So, fibrates, yes, they help. They can be difficult. They can be challenging to take in terms of side effects and side reactions. Omega-3s, as I mentioned, there's been several studies that have focused on this. The JELIS study, the Japan EPA Lipid Intervention Study, was originally looking at some statins like pravastatin and simvastatin, but in conjunction with EPA. Statistically significant improvement in cardiovascular disease. The STRENGTH study is currently ongoing, and guess what? The REDUCE-IT study, yes, just came out earlier, late last year, earlier this year. 25% decrease in major cardiovascular events. So again, yes, these things do work. And again, those are omega-3s, or what many people know as fish oils, and krill oils, and some of the other sources. We mentioned triglycerides and niacin a couple of times already, and I've already, like as I said, I've covered AIM high and HPS2 Thrive in other videos. These, bottom line, again, there was an improvement in the biomarkers. In those two studies alone, they did not see a decrease in heart attack and stroke. It was a big surprise. Everybody wanted to throw niacin out, and throw a niacin out, for example, along with lopropiant, very analogous to throwing the baby out with the bathwater. If you get, as they mentioned here, as you get deeper in terms of the analysis and sub-analyses, it goes back and shows that yes, you do get a decrease in cardiovascular risk. So again, got pretty deep, pretty geeky, and pretty long. For those of you that have made it this far, gosh, I'm impressed, and thank you very much. If plaque is the #1 cause of heart attack, stroke, dementia, blindness, kidney disease, you'd think we'd know how to evaluate it, screen for it, wouldn't you? Unfortunately, the state of the art right now is a guess, and a bad one at that, Framingham. The most common thing that you do is you say, well, hey doc, why don't we do a stress test? They don't work either. Then you go into the cath lab and get a definitive test, but that involves getting a needle in the groin. It just goes downhill from there. Now, there are better ways. Take a look at our plaque evaluation course. Click the link below.